have a great opportunity today. I have to admit, I don't really know Dr. Blumberg, and that's a good thing because I haven't had the infectious disease to worry about. But we all have the heart transplant, and we all want to know what the symptoms are to be aware. And so, on behalf of Second Chance, which is a heart transplant support group here in just the Philadelphia area, okay, we're talking about 800 heart transplant recipients who are members of this little group. I got to tell you, on an annual basis, with like 50 plus people being transplanted here, we get like one more member. So that 800 is like the tip of an iceberg. But I want you to know that. So on behalf of the officers, especially Dan Smith, welcome to the Second Chance event that we partner up with the hospital. And today, on the flyer, so you already have all this information. By way of introduction, Dr. Blumberg has got all the credentials to really be the doctor we need when we're facing that infectious disease issue. And a number of you here, I know, in communication when you registered and so forth, have either just seen her yesterday. In fact, a couple of them apologized. Steve said he couldn't make it today. He saw you just the other day. He apologized he's not going to make it. He's not feeling well today. So anyway, with that background, we're going to very quickly go into Dr. Blumberg's presentation. And then later on, we have some additional stuff, and she'll have time for question and answers later. So if you want to move on to...
Well, welcome. I'm glad to see so many intrepid souls here today because, honestly, I think that I might be bringing the bad weather since every time they've scheduled this, it seems to snow. But so thank you for being here. What I'm going to do over the next, I would say about a half hour, is I'm going to just give you an overview, and then I thought I'd leave a lot of time for questions because I know that when we talk infectious diseases and complications after transplant, there are always a lot of questions. So, first of all, I think as we think about this, your new hearts, your transplanted hearts have offered you a wide range of opportunities and new horizons. And as you sort of went through this process, you started out with a big educational learning curve. And most of you probably remember when the transplant NPs came into your room after the transplant with what seemed like an unending amount of information that you had to process. Some of these were do's, but it seemed like a lot of them were don'ts. And the biggest area of don'ts probably had a lot to do with infections. And so what I'm going to try to do over the next half hour or so is dispel some of the myths and give you some, what I hope is practical advice that may be something you can take home with you. When I thought about this, I first was going to start with sort of almost like a David Letterman top 10, and then I realized after I made the top 10 that actually was beyond 10. So I call this the top 10 plus questions that I've sort of been asked over the number of years that I've been doing this. And I thought I'd start with something really basic and important, which is, why are we having this conversation anyway? What makes a transplant patient different when it comes to infections? So I'm going to kind of run through a few things. The first is that transplant patients are a little more susceptible to infections than the average person. And the big reason for that is the medications that you're getting to prevent you from rejecting your transplanted organ. And so we give you a lot of things, and what they do is they attack different, very specific parts of your immune system so that the organ is welcome, but it also attacks certain important parts of your immune system that may make you a little more susceptible to very specific types of infections. So the immunosuppressants are a large part of it. Now, some of those effects are going to be very important very early on and then go away with time. For those of you who get weaned off steroids, some of the impact of that then will eventually go away. But some of them are going to be with you sort of indefinitely, although as the doses get decreased, the impact is going to be less. The other thing is, once you become a patient, you kind of lose your normal boundaries. Now, sometimes this is very obvious when we are sitting there sort of not really paying total attention to issues of modesty and things of that sort. So we sort of invade your personal space on many levels, but on some extent, we're invading them by, for example, some of you need intravenous lines, and after a transplant, people are on ventilators, on breathing machines. So there are certain ways that we invade your own normal host defenses that are just unavoidable after transplant. So there's some ways that we sort of make you more susceptible, the infections, the lines, the interventions, the catheters. But there's another issue, and that is that because of all of this immune suppression, sometimes the infections are harder to recognize. Some of you who've had infections may have noticed you didn't actually have fevers with them. That may be the immune suppression. There may be some signs that we normally see that are going to be less obvious because you're a transplant patient. So sometimes they're a little harder to recognize, and that means that the infections are delayed in their recognition, which may make them a little bit more complicated in terms of treating. The other thing is, sometimes we see infections in transplant patients that are due to organisms that are in our environment that actually wouldn't be a problem if we weren't giving you these additional medicines to affect your immune responses. So, for example, there are certain things that would be very minor or not cause problems at all, but now because you're a transplant patient, we start to worry about a little bit more. And so sometimes the actual infections are a little bit different. But the other thing is that sometimes very minor infections can be a lot more severe, especially in those first couple of months after transplant. And so we know that we have to take special care and try to recognize things early so we can prevent them from becoming more severe. The second question that I'm often asked is, where are all these infections coming from? So after a transplant, I think that as opposed to sort of some popular misconceptions, people aren't housed in bubbles. We return you. Where do we return you to? We return you to the hospital. Never a good place to be. We expose you to your donor. Usually not a significant issue, but there are some concerns that we may have. We expose you to yourself. And that actually can be a problem because it turns out the history of what you've had or what you've been exposed to can sometimes be very important in the post-transplant setting. And finally, with lots of, exposures, we bring you back to your community, whatever that community is. And we know that those communities are not sterile boxes. And so we're going to expose you to life. And that's, in fact, the goal of transplantation. But it can pose its own unique challenges. Now, what those challenges are depends on your timing after transplant, because it turns out that your susceptibility to infections actually is going to change with time. So early in the post-transplant period, what's going to happen is you're going to actually have infections that are much more likely to be related to what we're exposing you to in the hospital setting. So you have a surgical wound from your transplant surgery, and if you've had a lot of heart surgeries before you get to the transplant, the tissue there is a little more susceptible to infections because it's been cut so many times. We give you intravenous lines and urinary catheters, and that's a good way to bypass your own normal boundaries. So those can be infected also. People are both on ventilators, but also after a surgery, you may not be able to take as deep breaths, and so pneumonias are a little more common in the first period after transplant. And unfortunately, what we're starting to realize is our hospital, and in fact, just the exposure to antibiotics in general, does predispose people to getting what we call infectious diarrhea. And the most common thing we worry about is something called Clostridium difficile, or C. diff. And some of you may know people who've had it or even had it yourself. And so in the early period, we're looking sort of at the types of things that we may have exposed you to in your own hospital environment. With time, you're out of the hospital, you're back in the community. But this is the time, this period of 1 to 6 months after transplant or thereabouts, where your immune suppression is at its highest amount. Because this is the time where your organ and you are sort of finding that common ground, and you're on a lot of immune suppression. Some of you may have had rejection episodes and need to get more immune suppression. But some of you may still just be coming down off the large amount that you started out on. And so this is the time when we think of those sort of unusual things happening. Respiratory tract infections, pneumonias, urinary tract infections, just like before. But it's also the time when we start to worry about what we call the opportunistic pathogens, of organisms that might not cause infection if you weren't on immune suppression, and that may be a little more unusual in the general population. And so things, the big one here is cytomegalovirus, but probably one of the most common ones are skin warts. Many people find that after transplant, these little tiny warts that maybe they had once or twice before, that seem to be taking over their hands and feet. And that's because at this point, after transplant, this is when you're on the maximal amount of immune suppression. After you get past this sort of maximal immune suppression, then we start to see the things that you may have that you get from being around in the community. These are sort of the common infections, and as always, we're still talking about pneumonias and in some cases urinary tract infections, but we're also talking now about things like having gallbladder infections or other things, you know, skin infections that may just be commonly found in the community. Now, why is this happening? It turns out that we sort of have you in a fine balance. We know that your own immune system is a little bit weakened by the immune suppression, and in fact, needing a heart transplant itself, we know that going into the transplant, having heart failure, actually puts you at a little bit of an increased risk for infection because your immune system's not working that great before you go into transplant. We also know that there may be other infections that may happen in this early post-transplant period that may affect your ability to fight off some of the other infections, and so infections may lead to infections. We also know that there are certain things that are going to happen in terms of your exposures, both in terms of the donor, the hospital, the community, and yourself, that are going to be a little bit predictable. And so because of that, we now start to talk about medications that may prevent infections, okay? And so we know that for each of you, we do sort of a risk calculation. What infections are you at risk for, and what is the time frame for your risk period? So if you have a lot of rejection, that time frame may extend. If you don't have so much, then the time frame may be less. And so we choose medications during that period that are going to effectively prevent the infections that are occurring during that high-risk period. And these choices are actually based on clinical studies that have been done on patients just like yourself. So they're actually based on information that we have. So for example, patients after transplant are typically put on Bactrim, and in many cases on valganciclovir, or Valcite, and then nystatin, swish and swallow. And the reason is because we know that during certain periods you're at risk for particular pneumonias, for cytomegalovirus, and for yeast infections of your mouth. And so these are medications that are going to prevent infections. You might say, well, why don't I just stay on them for life? Why are you stopping them? Am I going to be at risk when you stop? Well, it turns out that with time, your risk for some of these infections is really going to dramatically decrease. Every medication has potential side effects, and I'm sure that all of you are grappling with the fact that some of them are not well covered by your insurance, and so it sort of adds to the hefty tab of transplantation when we actually do this. And so we do a sort of a risk-benefit assessment, and that determines how long we continue you on these. Perhaps the infection that you hear the most about, or that people talk about a lot, is cytomegalovirus. So I thought I would just take a minute and sort of dispel some of the myths and give you some information about cytomegalovirus so you'll understand what we're concerned about. So cytomegalovirus is a very common viral infection. In the United States, most of us acquire it in childhood, okay? But you can acquire it in a whole variety of ways throughout your life. ways that people normally acquire it are the exchange of secretions. That could include saliva, it could include blood, it could be passed sexually. But commonly what happens is kids pass it to one another in childhood by like doing things like putting toys in their mouth and handing it to the next kid. And so most of American adults are actually infected by the time they reach adulthood. So one of the things about this infection is it belongs to a group of viruses called the herpes viruses. And those are the same things that cause cold sores in your mouth or the monovirus. And the problem with the herpes viruses is they're like your gift for life. They all have the ability to stay in, sleeping in your body until they have that great opportunity to wake up. So most people, when they acquire it, they actually have no symptoms from it, or minor symptoms if they're a normal host, not a transplant patient. And then when it, just sits there until something happens that awakens this virus and gives you symptoms after transplant. And so they all live in various places, and cytomegalovirus lives in lymphocytes, so a particular type of white blood cell. Now, in general, as I said, most people have had cytomegalovirus before they get to transplant. But the flip side of this is so have most of your donors. It turns out if we were to say we're never going to use donors with CMV, there would essentially be almost no transplantation in the United States. Because this is such a common virus, we can't exclude people who've had it. And that's true whether you've had it yourself or not. So what do? We actually look at you and your donor to see if you've had cytomegalovirus. And then we think about this and use that information to decide how we're going to prevent it. Now, the problem is that while in people who've never been transplanted, this is usually not even recognized as an infection, or sometimes people will just have like a little flu-like infection that they don't identify as cytomegalovirus. In transplant patients, you can get sick. And the reason you can get sick is because the immune suppression we use specifically affects your ability to fight this virus. And so we often see cytomegalovirus. It's probably the most common of the so-called unusual infections we see after transplantation. Now the problem is that it's a very nonspecific finding. And so a lot of times when people have it, they may not recognize it initially. You might just feel a little off. You might feel kind of a little fluey. Sometimes you have some version of stomach upset, and that can be anything from indigestion to rip-roaring diarrhea. But the presentation can be extremely variable. As the transplant staff is monitoring your blood counts, they may notice a dip in your white blood cell count or your platelet count, and that may tip them off that maybe, even though you don't feel bad at all, that maybe the cytomegalovirus is starting to come up. So then we have to start thinking about diagnosing it. So we're very attuned to this, especially in the periods of time when you're not on preventive therapy for it, but you're still not that far from transplant. And so we look for it. How do we look usually? We look with blood tests to begin with. But in some cases, blood tests aren't going to give us the answer, and we may actually need to do biopsies, usually of the intestines. Now, you may say, okay, well, what's the big deal? I'll just go to my local hospital. And for some of you, your local hospitals actually are hospitals that have a wide variety of laboratory services. But for some of you, those local hospitals may be small community hospitals that do not do the type of tests we need on site. And they also, if they do them, may actually take weeks to come back. And so for this reason, it's very important when we look for this infection that we make sure you're getting the test done in a place where we can diagnose it rapidly so we can start treating you rapidly. So you won't get sick or sicker. Now, there are a wide variety of medications that we can use, but primarily we use either ganciclovir, which is an intravenous medication, or an oral medication called valganciclovir, the same thing that many of you were on to prevent CMV in the first place. Now, You may say, well, how do you decide? How come this person got IV and this person got oral? What's the big deal? It turns out that we decide what we're going to give you based on a variety of things. The first is, we look at see how sick you are. The sicker you are, the more likely we are to give you intravenous medication. Because we want to make sure that we're giving you medicine, that we know what the levels are going to be, and that we're fighting it as aggressively as possible. We also might choose to give you intravenous medication if we think your intestines are involved, because if your intestines are involved, then we want to make sure you're absorbing the medication. The third time we may choose to give you intravenous medication is if we're having problems with your kidneys, and so we're not quite sure how to dose the pills. And so in most cases, we do start with intravenous medications for one of these three reasons. And it's sometimes with time, we'll switch to pills. Okay? Whatever we give you, though, it's very important that you take it specifically as directed. Why? Because if there's any problem with how you're taking it, and sometimes even for other reasons, you may wind up to have virus that becomes resistant to these standard medications. And then we have to start using other things, some of which can affect your kidney function. And so if we put you on it and you're having some issues with it or there's concerns, we can certainly try to adjust things as need be, but we want to make sure that we're treating you as need be. Afterwards, you may notice that some of you actually stay on valganciclovir for a little while, and some of you don't. How do we decide this? Well, it turns out that we make this decision based on sort of what's happened to you before and whether or not you've had issues with rejection. So if you've had a lot of problems with rejection and your immune suppression is going to be higher, we might say, you know, we're going to do something preventive for a little bit longer. But if you haven't, we might say, you know, we're just going to stop, and what we're going to do is we're going to get blood work on you. And this is why we sort of torture you with weekly blood work for a little while after you've had the CMV infection. We want to make sure that what we did was the right decision. I'm going to switch gears a little because I think in the United States now there's a lot of concern about vaccines, you know, and so I'm going to actually sort of give my little anti-Jenny McCarthy thing here. You know, from an infectious disease standpoint, probably one of the biggest advances in our field has been the development of vaccines to prevent all kinds of infections. We now know that there are vaccines that prevent pneumonia, that prevent flu, prevent cancer. Lots of vaccines. And so from an ID standpoint, the best time to deal with infections is before they occur, and one of the best ways to do this is to vaccinate people. And so it's really important, and it's especially important for transplant patients, because some of these vaccines actually are really active against things that bother transplant patients a lot when they're out in the community trying to live their lives, things like pneumonia and the flu. And this flu season has been a particularly challenging one for those of us in Philadelphia. So we now have vaccines to prevent a whole lot of things. The ones you're going to hear about most are the flu vaccine, hepatitis vaccine, and pneumonia vaccines. But we also have other vaccines we might give you, let's say if you plan to travel somewhere. And I'm going to talk about travel in a few minutes. When should we start? Well, the best time to start vaccinating people is before they ever get to transplant, because it turns out your history of vaccination actually is going to impact on your ability to respond to vaccines after transplant. Now, sometimes some of you were very, very sick acutely, and people didn't have time to tend to your vaccine issues. And I think with time in the United States, the trend to vaccinate well people is now increasing. So before we used to reserve flu vaccine for limited numbers of people. Now we think everybody in the U.S. should get flu vaccines, because it turns out influenza is something that actually can wreak havoc even with normal people. we sometimes, based on your age and what your issues were before transplant, you may not have gotten hepatitis vaccines, or you may not have gotten the pneumonia vaccines. And so I understand that some of you may not have been fully vaccinated before transplantation. But whenever possible, and as you meet people who are going through the process of evaluation, this is important. Their vaccines should be evaluated before transplant. We also know that a lot of the vaccines we give you, they're not one and done. You're going to need revaccination. That's true for annual flu vaccines, but it's also true for the pneumonia vaccine. And every year, there is some tweaking of the vaccine recommendations. So some of you have come to my office and I say to you, oh, you need a pneumonia vaccine. You go, I got that. I got that 2 years ago. Why don't you? I thought it was every 5 years. And it turns out, in 2013, they changed the pneumonia vaccine recommendations. And so the recommendation now is to give a special pneumonia vaccine that actually was originally trialed in children, but turns out to be more effective and is a good way for boosting immunity in immunosuppressed people, including transplant patients. So it's important for us to think about this. Now, at this point, we don't think transplant patients should get live virus vaccines. The big one for you guys, shingles vaccine. I get a million questions. I'm reaching that age, or this audience doesn't look like anybody's reaching that age, but someday you will be, where, people talk about flu vaccines. Shingles vaccine. And the thing about it is that right now, in 2014, we say no to live vaccines. This may change, though, because it turns out that with adults, this isn't such a big issue, but for little kids who need transplants, they were due for a lot of live virus vaccines, and some of them missed them. And so people have started looking at doing things like giving little children who need vaccines after transplant, things like the chickenpox vaccine. And actually, it may be okay. But we're not ready to do that for you yet. So right now, we say no live virus vaccines. Now, what does this mean for the people you live with? Well, there are some live virus vaccines that your household members cannot get. So let's say you have a household member who is in the military and they're supposed to get the smallpox vaccine. You got to stay away from them when they get it. Or let's say your child is in school and they want to give them the nasal flu vaccine, that live virus flu vaccine. We don't want them to get that. Unfortunately, we want them to get the shot, which is the killed vaccine. And so that's going to be important to do that. So we want to know what vaccines your kids are getting, your grandchildren are getting, your siblings are getting. But most of them that you're not going to need to be staying away from them, but we want to know what they are just in case there are a few that might be important. Which vaccines do we expect you to get? We want you to get flu shots annually, both before transplant and after transplant. That doesn't mean it's always going to work, but we think that even if it works partly, it may make your illness a little bit milder. And we know even in normal people, not that you're not normal, but in people who aren't transplant patients, that flu vaccines aren't perfect. But we're going for what we call the herd effect. If we protect enough people, then there'll be less in the community, and maybe you'll be protected also. We want you to get the pneumonia vaccine, and as I talked about before, this has changed a little bit in terms of the recommendation. So we want to know when you've gotten it, and we'll figure out when you need to be updated. We're getting really big on hepatitis B vaccine. Why is that? Because we think, first of all, hepatitis B is a bad thing to get to begin with, but also it turns out that we think that this may be protective in case there are some issues in terms of donors. Okay, in general, we don't use donors who have active hepatitis B, but there's this whole group of donors who may have had past hepatitis B that in order to feel we've extra protected you, we'd like you to get hepatitis B vaccine. And the other thing is, we're very interested in making sure that everybody here has had the tetanus shot that includes pertussis, whooping cough. Why is that? So there's actually two things about this. The first is that adults have always been susceptible to whooping cough because it turns out even if you got vaccinated as a kid, by the time you're an adolescent, that vaccine immunity has like gone away. Now, we never used to vaccinate you because the old vaccine actually had components that caused a lot of reactions. But the new vaccine actually is very well tolerated, and so we think it would be important to protect you because adults who get whooping cough, they don't whoop, but they cough forever. And this is true with people who've not been transplanted, but it's especially true with transplant patients. And it may not be recognized initially what it is, and so it may go on even longer. And so as a result, we want you to be protected. The other thing about it is it turns out that the vaccine recommendations for children have changed. And so we used to think children were protected until maybe adolescence, but it turns out the current vaccine doesn't last as long in kids. And so there's probably more pertussis in the community. And so your children, grandchildren, neighbors, relatives, they may be seeing more pertussis as well. So it's important that you get that vaccine. Now, there's a lot of concerns about vaccine safety. I want you to know all vaccines are regulated by the FDA, and they still do intense reporting of adverse events. So really, vaccines have been looked at pretty closely, and they continue to be on a daily, weekly, monthly basis by the government. But the other thing is, the most common thing I hear is, I don't want that flu shot, I always get the flu afterwards. So it turns out that the flu vaccine that we give transplant patients is not a live virus, it's not even a whole virus, it's pieces of the virus. So you can't get true influenza after you get the vaccine. You might not feel great in some cases, but you're not getting the actual flu. And in general, it's pretty well tolerated. And so it's a myth, you can't get the flu from the killed flu vaccine, the one that's the shot. Okay. Now, when Maria, for example, or I think I saw Mika in this room, walk in and they talk to you, one of the things they say to you is they ask you if you have pets. And you may think, what a cold, heartless world this is. They want to take my pets away from me. But there are some precautions when we talk about animals. Now, in general, the pets we don't care about, that we say go for it, are dogs and cats. Now, we're not great on kittens. This isn't the best time to acquire a new kitten in your first 6 months after transplant. But dogs and cats, they're just fine. But there are a number of pets that don't make great pets for transplant patients. We're not crazy about birds, because birds can carry a variety of things, one of which includes a fungal infection that I've seen in patients. I had a patient once, not a heart transplant patient, but another patient who actually decided he was going to do a kindness for his daughter, and birds hit for her cockatoo. The cockatoo was not cage trained, flew all around the house, and wouldn't you know it, 3 weeks later, he had a bad fungal infection of his brain. So birds, not so great. Monkeys, I doubt any of you have monkeys, but they are also bad things. But even things like turtles and lizards carry things like salmonella. And so they're not that warm and fuzzy to begin with, but I realize that that actually doesn't matter much for some people. But in general, those are probably not great. And the other thing that's probably not great for you to have are rodents. Because it turns out rodents sometimes harbor these asymptomatic viral infections that have been a little bit problematic. Now, if, for example, your job involves you working with these types of animals, we should have a discussion about precautions to take. Now, what about pets in general? Well, in general, we say don't get a new pet in the first 6 months after the transplant. Let's get you past the rejection things. Let's get you through some of this. Being a transplant patient gives you the opportunity to have a great excuse for avoiding cleaning the litter box, or remember I said no birds, but the bird cage if you have one. Some people are real pet lovers. You could be like that snowboarder in the Olympics who decided he was going to round up all the stray dogs in Sochi and take them on. But in general, we don't want you caring for stray animals. The thing is, they haven't been vaccinated. They could potentially harbor certain infections, even things that are diarrheal pathogens or other things. And so I think it's best to avoid taking in the stray cats and dogs in your neighborhood. And if you think your pet is sick, you should certainly take them to the vet and try to avoid contact with them if at all possible. Most importantly, you really should be using hygiene. You should be washing your hands following contact with your pets. You shouldn't let your pets chew on your IV tubing, lick your wounds, you know, all things that I unfortunately have seen and have seen wind up not causing great outcomes. So, you know, just be a little mindful. You know, we certainly are cognizant, dogs and cats, and, you know, pets are an important part of life, so we just ask you to use some common sense. What about hobbies, jobs? Now we're talking returning to life. Some of you are avid gardeners. Some of you work in situations where you have a lot of soil contact or you're involved in construction issues. Some of you love to swim and you've always really enjoyed swimming in freshwater rivers and lakes. These are activities that really need to be discussed so we can look at what your specific risk factors are and consider. Why? Because it turns out that sometimes this gardening activity can wind up giving you a fungal infection or bacterial infection, and we could have thought of ways to actually prevent it up front. We would prefer that you not do a lot of soil exposure in the first year after transplant, so we get you past that maximal immune suppression thing. In general, I would say this to anybody, not a transplant patient, you shouldn't be drinking from freshwater lakes, ponds, streams. It's a good way to get intestinal pathogens, so things like Giardia, and that's like the diarrhea that just keeps giving. And so you just really want to make sure that you're watching what you're doing. And if you commonly are a swimmer in rivers or lakes or have a lot of freshwater exposure, we really should talk about what you're doing and try to figure out what ways we can tweak your activities. So before you return to these beloved hobbies or maybe less beloved job, I'm not sure, you should really review your activities with the transplant program. You should make sure you're washing your hands frequently, you wear gloves when gardening, and you avoid areas that have mold, bird droppings, fresh fertilizer, or decaying plants, including compost heaps. Now we get to the nitty-gritty, food. You finally got your taste back. You're ready to go for it with gusto. And yet, now I'm about to, you know, dash those hopes a little bit. We know that there are certain foods that are clearly associated with infection risk, and that's especially if they're raw and undercooked, okay? So undercooked meat, poultry, seafood, raw meat, poultry, seafood, not great ideas. Because even in non-transplant patients, we know that raw meat has been associated with some really significant infections. So when you're cooking that goulash or whatever, don't taste the beef while it's undercooked. Okay, wait till it's cooked. We really don't want you having unpasteurized dairy products or juices. Same reason, they actually can harbor bacteria that can make you pretty sick. And raw eggs really are also to be avoided, even if they're like mixed in with a hollandaise sauce or something like that. What about cold cuts? So periodically in the United States, we have outbreaks of things like Listeria, which is a foodborne intestinal bacteria, which have been associated with cold cuts. So for those of you who like a good roast beef cold cut sandwich, what I say is have it once, but don't buy cold cuts for the week and eat them every day, because it turns out refrigeration does not kill that bacteria off. And so, in general, if you have to have cold cuts, do it as a one-off thing. Buy just what you're going to eat that day. One of the things that's important for everybody, not just transplant patients, is to practice general food safety, which means wash your hands before you prepare your food and after handling the raw foods and before you eat, because you don't want to ingest the bacteria. And most of all, do not use the same cutting board and utensils for the raw meats and the uncooked vegetables. In other words, you're making a salad, but before that you actually prepared, you cut some raw beef to throw in a stew. don't use the same cutting board. Make sure that it's not a porous wood board and that you've washed it off well before you're going to use it again, because otherwise you could get sick. And this is not just if you're a transplant patient. This is anybody. What about travel? You know, being a transplant patient now is going to open you up to a lot of possibilities that maybe you didn't have when you were sick. And one of those is travel. A very dear friend of mine is now celebrating the 32nd anniversary of her liver transplant. And she has been in parts of the world that I will never see. All courtesy of her gift of life. And so I want to tell you that travel is possible, and it's possible to most parts of the world. I have a patient now who I see really just to give him travel advice because he's traveling all over the world. However, I will tell you that before you embark on your worldwide tour or even your trip to, you know, Arizona, we should talk a little bit about general precautions. And so before you book any trip, you really should just tell the transplant team you're going at least a month before you go, preferably before you buy the tickets though, so we can think about what needs to be done in case some things require vaccinations that may take a little more time. We want to think if you're traveling to the developing world, South America, Africa, Asia, where you're going to get your food and water so we can make it safe. We want to vaccinate you for things that you might need prevention. And so periodically in parts of the world there may be polio outbreaks. And we actually have a pretty good injectable vaccine for polio. We want to make sure that's updated. You might be going to Mexico and we might be worried about hepatitis A. Let's vaccinate you before you go. But we can't do it and you leave the next day. We need a little time. A lot of times when you travel places, you might go someplace that there's actually insects you have to worry about. That actually could be true here in the United States too. We periodically have sort of insect-borne infections like you might hear about West Nile virus. And so if you're going someplace where there are insects, we want to talk about insect repellents and clothing and whether or not you need to spray your clothing or whether you might want to choose times of day to be out when the insects are going to be less likely to be out and biting. And so those are some things. In general, if you're going to go more exotic, we want to think about what the local medical resources are and make sure that we've thought about them so that we have an emergency plan just in case. I tell this to people who travel in general. We have a travel clinic in our office, and we say to people, think about where you're going. Even if you never had a medical problem in your life, think about it and what you would do if you got sick. So in general, if you're going places where we're worried about food and water, we say don't drink the tap water, don't put ice in your beverages, don't use beverages that are going to involve tap water, don't drink the fresh fruit juices, or use any unpasteurized milk or dairy products. There's sort of a saying that's a travel medicine saying in these places where you might go where you worry about this, which is boil it, cook it, peel it, or forget it. So in general, what are the most important things you can do at this point to protect yourself? The first thing is we want you to stay away from sick people. So you had your transplant, you leave the hospital, you feel great, you're ready to go out in the environment, it's Christmas time, you want to do that big mall shopping or go to some big family gathering. Try to avoid the crowds in the first few months. If you want to go shopping, don't pick the highest times with the biggest crowds to do it. We want you to remind your family that it's good to have some general guidelines. So they should maintain their health. They should be vaccinated appropriately, especially flu vaccines for family members. And everybody should learn to wash their hands. Washing your hands is probably one of the best things you can do to prevent infections. In general, transplant patients have a little bit higher incidence of diabetes. The medications we give you sometimes can be a problem, and some of you were diabetic before. And when you're diabetic, one of the things we really want you to take good care of is your feet, because the feet are like the gateway into your health. And so we really want you to make sure you're not wandering around places barefoot, where, in your house, yes, but not like outdoors, walking in the dirt. If you're at a swimming pool, obviously we don't expect you to swim with shoes, but just use caution about being barefoot. I mentioned insect repellent. It's really important, even in Philadelphia, in certain seasons when we have West Nile, to, try to avoid like a lot of mosquito exposure. And if you get a cut or a scrape, you should really make sure you're cleaning it immediately with soap and water. I had an interesting experience recently with not a heart transplant patient, but with another patient where he had a little trauma with a local pet, his daughter's dog, and he just didn't have time to do anything with it. And so he kind of pushed the skin back and got around to later, well now, 3 months later, he needed orthopedic surgery. So, try to attend to these things early. And if you have any questions, any concerns, really, you should call first. Just call. We're here. There are lots of people to answer your questions. We want you to call if you have questions to prevent. Call if you think you're getting sick. Call if you have any questions. Because transplantation is really about returning to life. And the last thing you want to do is see me. So, in general, we're here to answer your questions. My colleagues and I, some of you I've met before, some of you may have met either Dr. Weichert or Dr. Wilk or Dr. Barton. We're here basically, to keep you from running into trouble down the road. So I'm happy to take any questions. Yeah?
I see ads on TV for certain supplements, vitamins and minerals, that proclaim that they boost your immune system.
Yeah.
And I kind of hesitate to take anything like that because I think I'm kind of defeating the purpose of my immunosuppressants.
Okay. Well, a lot of those claims are, let's say, overblown. In general, most of the things that they say are going to boost your immunity probably really have very little to do with that. And the difficulty with supplements is that some of them have additives in them that actually may affect your own medications by causing interactions with them. So in general, I would say avoid supplements. And because they really don't boost your immunity in any meaningful way, and in some cases they have a lot of adverse problems with them. And I'm glad you brought that up, because one thing I do want to say is, some of you live far away, and when you get sick, the first thing that the transplant folks may say to you is, well, go to your local doctor and see what they think. Some of your local doctors are amazingly knowledgeable about transplantation, and for some of you, you're the first transplant patient they've ever seen. When they prescribe a new medicine for you, before you fill that prescription, you really should call the transplant program, because one of the things that we've discovered is sometimes they'll prescribe, let's say, something like Cipro, and Biaxin, and you go to take it, and then the next thing you know, you're having problems with your Prograf levels or your Neoral levels, and it's a huge issue, and you go, well, why did this happen? It turns out some of these very commonly used and effective medicines have really important drug interactions that we need to plan for before you start taking them. And so if you get a new prescription, before you fill it, call the transplant program and say, is there a problem? And we're very lucky because we actually have pharmacists who work with us specifically so that we don't immediately know the answer. We can get the answer pretty immediately from them, because we do want to make sure that we're not running into unnecessary complications because people didn't realize that there might be drug interactions. And, it happens, because the fact of the matter is not everybody gets their medical care in a place where there's a lot of transplant patients, and your doctors may be very good at doing a lot of different things, but the lack of familiarity can sometimes lead to some unanticipated problems. Yeah.
Supplements that include like the probiotics for stomach.
That's a good thing. So a lot of you have intestinal issues from the medications, and there's always this sense about whether or not probiotics are good. And in general, we say no probiotics. But every once in a while, things like Saccharomyces, that brewer's yeast, for example, winds up in your bloodstream and causes infections. So best not to do probiotics. Every once in a while, we may put you on something in general, it's best to avoid without discussing first. Yeah.
I wanted to switch gears a little bit. You had mentioned something about the immunizations and not having active immunizations, either to somebody in the household or to grandchildren or nieces, nephews, whatever. If they do get them and they're not in the immediate household, but you're around them on a frequent basis, what is the time period you need to be away from them?
So that's actually a really good question, and what I would say is it really depends. So everybody in this room is an adult, which means that the odds are a lot of the things that we're vaccinating kids for, you've either had, or in some cases you might have been vaccinated, but probably many of you have had these, infections. And so there may not be any time frame that you need to be away. The one that we used to be really worried about was polio vaccine, because they used to give kids oral polio vaccine, which was a live vaccine, and it turns out for those of us who were vaccinated as children, we don't probably still have very good immunity against polio. And so what would happen is the kids would get vaccinated and then the parent would be taking care of their diapers or whatever, and they might get what was called vaccine strain polio infection. It turns out so did some of the kids. So they stopped using that, and now every kid gets the injections. Some places out of the United States, they're still using some oral polio vaccine, but so in general, that's not an issue. On the off chance that you have never had chickenpox, and your child, grandchild, needs to get varicella vaccine, we want them to get the vaccine because we sure don't want them to get chickenpox, because that would be a lot worse for everybody. And in general, if they don't have a rash, it's not going to be a big issue.
Okay.
So there's no specific thing, but if you know like somebody in your close inner circle is getting a vaccine, we should talk about your individual situation.
So I guess my basic question is like the MMR or something like that.
Yeah, so in general, most of those are fine and the kids should all get them. We want the kids to be vaccinated on schedule, and the odds are it shouldn't be a significant issue.
So there's no reason to stay away from them after they've been vaccinated?
Not generally speaking. In some specific cases, we might say yes, but the vast majority of people here should actually already have been vaccinated or have infection, and they should be protected. Yeah.
I have a question relating to the kitty litter boxes and stuff.
I'm sorry.
The kitty litter boxes?
Yeah.
And the pets?
Yeah.
I do have a bunch of indoor-outdoor pets, but one of them we just acquired was rabbits that are kitty litter trained. Is that also something? I mean, I'm 4.5 years
Yeah.
out.
So in general, when we talk about litter boxes, we think that the poop should be scooped on a daily basis, And so the longer it sits there, the more likely that certain organisms we worry about can sort of become infectious. So in general, if you're scooping a litter box, what I would say to you is, if there's somebody else who can do it in your house, get them to do it, but daily. If there's not somebody else who can do it, then you should wear gloves when you do it and wash your hands afterwards. Yeah.
You mentioned the smallpox vaccines. My daughter just had a transplant yesterday, and my son-in-law is in the military.
Yeah.
How long?
So in general, when he probably has been vaccinated already. So we're really worried about in the very early period. After a smallpox vaccine, they typically develop a reaction at the site. It can be a very minor reaction, but that reaction has the potential to have live virus there. So if it's covered, they're not touching, they're okay.
Okay.
But in general, a lot of the military vaccinations are done when they're not necessarily around family members anyway, because they just get a whole bunch all at once. But that's a vaccine that you definitely do not want contact with.
Do a lot of patients get bacterial infections, or is it just
No.
specific cases?
It's specific cases. So there's a type of family of bacteria called mycobacteria, which includes tuberculosis, which we're fortunate in the United States, we don't actually see much TB anymore. But there are also, we're coming to appreciate here, throughout all the transplant programs in the United States, that there are cousins of TB we're now seeing. We see it a lot in lung transplant patients causing some lung infections, and we see it sometimes in other patients, sometimes causing lung infections, sometimes causing skin infections. And it turns out the reason this happens is these bacteria are common in our environment. They're found in soil, they're found in water, and that sometimes they can get under the skin and cause problems. And they're still pretty uncommon, but I think over the past 10 years, I would say the number I'm seeing is greater. It's not something for most people to worry about, but it is something that we pay attention to because there are things that are in our environment. And that's a good example of something that people who are not transplant patients might actually not have any problems with. Because in fact, in our drinking water, there's probably mycobacteria sometimes, these not the TB ones, but other ones. And we probably are ingesting them. And even in transplant patients, most of the time, that probably isn't a big issue. But unfortunately, sometimes it is, yeah.
If someone about a month out of transplant was to miss like 5 days of valsite and Bactrim,
Yeah.
could they get an infection? My
Well, so
husband-
that's a good question, is how much can you get by without getting? And we don't really know. There's no blanket answer. It probably depends on the individual, and it probably depends on a lot of things. The first thing is it depends on, did you ever have CMV before? Or are you one of those rare people in the United States that you didn't have it as an adult, but your donor did? So then in that case, if you've never had it and your donor did, your risk is probably a little greater with missing a few days. What kind of immune suppression you are on. Did you recently have rejection and now you're on more immune suppression? Or are you kind of like towards the end of the time we were going to give it to you and your immune suppression, everything's just going like clockwork and you're down on a very low dose of steroids and things are going on. And so that probably depends. Something like Bactrim, we know that we've changed how we've given it over time. We used to give it 3 times a week. In some cases, some people were getting it twice a week. And so there's probably a little more give with the Bactrim because it probably has more long-lasting effects. If your kidney function isn't great, you might get a little more these things might last a little longer because they're not being excreted by the kidneys as well. But in general, we really would prefer that you not miss. Because one of the side effects to missing something like Bactrim is sometimes you are on other medicines that interact with Bactrim. And a good example of this would be people who are on blood thinners like warfarin, Coumadin. Because if you're on Coumadin and you miss your Bactrim, your Coumadin levels, your clotting times are going to change, potentially. And so there's sort of other issues that may be part of this, although not necessarily big things to worry about. So if you miss a dose or 2, that may not be a big deal, but once you start getting into a couple of days, the risk probably goes up with each day you miss.
He was in rehab and they missed
Yeah.
five days
Yeah,
instead.
generally speaking,
And then he ended up with a major infection and had to have the
Yeah.
incision,
yeah, and so that may be part of it or maybe not. So, it's hard to know in each individual case, but we give them to you because we think they make a difference. Matter of fact, we know based on like studies that have been done that they do make a difference. So we don't really want you to miss them. If something happens, there's a major weather event and the mail order didn't come in, some of these things are sometimes unavoidable, but in general, we'd like you to get them. Whether that missing it in your particular case is what made the difference can sometimes be a little hard to tease out. Yeah.
I had a case of shingles this fall, and I felt kind of bad about it because it didn't bother me at all, and there were all these horror stories I heard about how awful it was for people. And then a friend, a physician, said, well, that could have been because you were immune suppressed, and so you didn't get the reaction to it.
So one of the interesting things about shingles is over the years, we know that shingles is more common in a couple of different types of people. First of all, it's more common the older you get, which is why there's now a shingles vaccine that's given to people at age 60. Because the older you get, the more likely you are to have it. For some reason, your own immunity to this virus that you had when you were a kid sort of tails off. We also know, though, that for some people who get it, that they get a lot of pain And in the past, long time ago, people did studies where they gave certain patients steroids to see how that impacted on their response to shingles. And so some people who got shingles actually had less pain with steroids. And so back when I was in training, the recommendation was to give people both an antiviral as well as to give them steroids to prevent some of this. It's possible that some people now have fewer issues in terms of pain with shingles because they're on steroids potentially. But in general, you know, we still worry that transplant patients, the net effect of the immune suppression is you may get both more severe shingles, and the other sort of funny thing about it is you may be more contagious to those around you who've never had chickenpox. And so if you were to get shingles, we do want you to be mindful of the fact that you might be the little vector affecting your non-immune friends and relatives. Yeah.
The shingles vaccine, if you are as the spouse of a transplant patient, is there a time period if you get the vaccine that you should not be?
That's a really good question. In general, most transplant patients have had chickenpox. And we know that if you've had chickenpox, being exposed, if you're a heart transplant patient, and it's a little different if you're a bone marrow transplant patient, but if you're a heart transplant patient and you've had chickenpox, being around somebody with shingles or chickenpox should not result in you getting chickenpox, and so the same is true for the vaccine. If you are one of those unusual people who is an adult in the United States and you've never had chickenpox and you've never been vaccinated, and that puts you in a minority, a really tiny minority, then being around somebody who had shingles vaccine, if they get a rash, might be an issue. But if they don't get a rash, it probably isn't an issue.
So let me rephrase my question. I've had shingles twice. I am not a transplant patient.
Yeah.
But I'm married to a heart transplant. If I were to get the shingles vaccination, which they keep encouraging me to do, will that have any impact on the transplant patients?
Probably not if your husband has already had, you know, chickenpox.
Okay.
But, yeah, not if your husband's had chickenpox. Yeah.
Two things. Now with the warm weather coming up, should we avoid swimming pools?
So that's a good question. In general, we say if you're going to swim, a swimming pool is probably the best place for swimming, but you want to make sure that the swimming pool, that somebody's tending to it and that it's chlorinated. So hot tubs may be a little bit of a different issue, especially if they're sort of hot tubs that are sort of unregulated, not your own hot tub, because there have been some cases, not even in transplant patients, of skin infections related to sort of not adequately chlorinated and maintained hot tubs. But you can swim in swimming pools, but just make sure that they're pools that somebody's paying attention to the chlorination and the hygiene of the pool.
And you said about unpasteurized juices.
Yeah.
Would that go the same with fresh fruit?
Well, so not like let's say you like to make your own juice, and you are going to squeeze. We don't really want you having grapefruits, but let's say you're going to take some apples in your house and cut them up and make your own apple juice. That's fine if you make it for one-time use and you drink it then.
Okay.
You know, so for people who love their juicers, that's okay. But don't make multi-use things and stick it in your fridge, because it turns out the bacteria that we particularly worry about, which primarily we're worried about it if you're going to the local farm stand to get this, because it turns out sometimes the equipment may be contaminated with this thing called listeria. Listeria is actually this bacteria that particularly is associated with foodborne outbreaks from time to time. You may have heard about it with cheese spreads, or there have been ice cream outbreaks and whatnot. It loves cold weather, and so putting it in your refrigerator doesn't help.
Okay.
So in general, unpasteurized products from farm stands should be avoided. Yeah.
When you talked about travel, if you find yourself on a cruise and they have an
The
outbreak,
norovirus, yeah. So, this has sort of become like a commonplace thing. You go on a cruise, you think everything should be fine, and all around you, people are being felled by norovirus. People who never had a medical problem in their life. A lot of this is a hygiene issue. And so what I would say is one of the problems with things like cruise ships, I don't know how many people here have been on cruises, I've been on one. You know those food lines? So you're standing in the food line and there's this big buffet and everybody's going down. You know, the hygiene on that is sort of sometimes a little problematic. And so what happens is it's those sorts of exposures where people aren't washing their hands and they're sort of in the midst of getting sick. That's really the issue. And so I think if you're on a cruise ship, you really want to avoid the activities, you know, if there starts to be little rumbles about this with like the big buffet lines and the things where you're sort of handling things that other people have handled without cleaning them. So let's say you want to go to the rec room on the cruise ship and use the exercise equipment. You really ought to make sure that you're sort of paying attention to your own hand hygiene. You know, so don't like go use the equipment and then just go eat. You know, make sure you're washing your hands well and stuff like that. And the same goes for, you know, just in general, you're probably better not doing the big buffet lines, but doing the meals where people are, you know, have their own individual meal. Yeah.
Couple pet questions. We have dogs that are hypoallergenic. However, one of them actually has allergies, and part of the therapy is to clean her ears.
Yeah.
And because she gets these ear infections, so my wife does it, but I sort of assist her. Should I be careful about that?
Generally speaking, that's probably not a big issue, especially if you're hand washing. So the things that are in her ears, you know, probably aren't going to be a major issue, but hand washing is always a good idea.
The second question, we don't have birds, we have ducks.
Yeah, those aren't so great either. Are they, I assume they're outside though.
Yeah, oh yeah, sure.
Outside.
Yeah, so, you know, outdoor pets, so people who have horses, ducks, you know, things that are outdoor that you're not in a confine with are not as big an issue, but hand washing is important. You know, and you don't want to be like cleaning the water around the ducks, if possible. So.
I never had chicken pox. What do I do?
If you've never had chicken pox, then if you're ever around somebody who does, we should know about it. But just hopefully people around you have all had chicken pox or been vaccinated.
Thank you.
Yeah.
And my brother's going to Afghanistan. I invited him to dinner. Should I ask him if he had the vaccines before he goes? Like, maybe he gets some, because I know
Well,
he's
you're
going...
not going to be up close and personal with him. You know, it may not be as big an issue. So the only vaccine we're worried about in his case is smallpox vaccine.
Okay, so I should ask him before he comes? Okay.
Yeah, but if he had it like a month ago, you know, if he's been in the military for a while,
Yes.
he's had that vaccine already. You don't get it multiple times.
Okay.
So if you know, they actually started vaccinating military after 9/11, and that became, I mean, the military has always been very heavily vaccinated.
Right.
You know, but the odds are if he's been in the military for a while, that he's had that vaccine.
Okay, good.
Yeah.
I have a question as far as like people getting chemotherapy and radiation. Is that something we need to avoid being around, or
No,
does that
no,
matter?
but you know, they're their own susceptible host from that. And so, you know, you just want to be cognizant of the fact that you may be the healthy one and, you know, be careful. So in general, hand washing is good with that too.
Have you had any problem with people getting either Bartonella or Lyme infections post?
Bartonella, hardly ever. Lyme disease, it's hard to live in this area and not get Lyme disease, or at least think you had Lyme disease. And in the case of our practice, we see a lot of people who were told they had Lyme disease, but in fact, never did. But we don't see that it's a huge, Lyme disease is something that there's plenty of good treatments for, and we don't usually see that it's a big problem in our transplant patients. I've never seen it be something that has been a particular issue. And Bartonella, I can't think of the last time I saw Bartonella in a transplant patient, so I think we just haven't had a lot of exposures to it.
When you're saying hand washing, do you prefer the soap and water?
This is actually a very good question. So, one of the things about hand washing is we don't want you to use bar soaps. Why is that? Ooh, bar soaps. Who would have thought, right? Bar soaps. Turns out bar soaps are a really nice culture media. So when they sit there in that little soap dish with all the little water stuff, and they actually, that's why there's no bar soap in hospital. You know, when I was in training, all the hospital rooms had bar soaps, but we don't actually use them for our own hand washing. So in general, you could use a pump soap, you could use a waterless hand hygiene, and it doesn't really make a huge amount of difference. The water part gets like the top, local dirt off, but in terms of just cleaning antibacterial, it probably doesn't matter as long as it's not a bar soap, with one exception. Let's say you or a family member has C. diff. I don't know if you guys have ever heard about this. This is a diarrhea that's sort of sweeping the nation, and it's related usually to being on antibiotics or having somebody around you who's been on antibiotics. And it turns out that waterless hand hygiene is not acceptable in that setting. You really need to use soap and water. Yeah.
I wasn't aware of the fact that you get warts, and now I seem to be getting them, but I can't get rid of them.
Yes, so that's a hard thing. Warts are one of these things that are sort of unsightly, annoying, but actually, in the vast majority of cases, not horrifically dangerous, but they're an unpleasant thing. And in transplant patients, they are very common, and they really reflect your level of immune suppression. And so, and it's funny because it's not necessarily the dose. It's the way your body interacts with whatever you're getting. And so for some people, we just say you become a frequent customer of the dermatologist. And sometimes there are topical treatments that you can do, that you can work with a dermatologist to do. And, they can freeze them, but sometimes we can't really do a whole lot. Now there's a vaccine, actually called the papillomavirus vaccine, which we think all young people should get because papillomavirus is associated with cervical cancer and potentially with rectal cancers and some other things. And we now know that because it's often sexually passed, that we can give this vaccine and it actually prevents the cancer-causing vaccine strains, at times where people are more likely to get it. Now that papillomavirus, there are strains of the same virus that cause hand warts that are just commonly passed in other ways. Unfortunately, the vaccine probably doesn't do much for a lot of the hand warts, but it's something that should be considered, especially in young people, including young transplant patients can get it.
I'm watching Dr. Blumberg's time because she has another talk to give across the street in just 10 minutes. So on behalf of the patients who are both here and those who are going to see this when we put up on YouTube, we thank you very much and offer you a book of inspiration 365 days a year, which I'm sure you can appreciate with all that you face every day. Thank you very much.
Thank you.
Thank you.
Thank you.
We've just got a couple more things before we wrap up and go out to lunch here. But I want to share with you something that I came across just recently, which I think is really an inspiration to all of us as we face our lives post-transplant. And just this past January, Dr. Wilhelm, I'm not quite sure who he is, I just picked up his article to read the full article, and he was giving a presentation at a pretty prestigious cardiology conference. And he says, and I think it's worth reading out loud, remarkable number of patients survived 20 years or more following heart transplantation, confirming the procedure as the gold standard for end-stage heart failure, at least for the time being. With continued improvements in immune suppression management in the coming years, we expect to see transplant patients living longer, healthier lives. It's still uncertain if mechanical circulatory support devices will be able to compete with heart transplantation in the future. For all of those of you who've had your heart transplant, it really is an amazing thing to go through. And I share with you a picture from a second chance dinner dance back in 2009. And to the best of my knowledge, every one of these guys and gals are still alive. And so add, 2014, add 4 more years to that, huh? And at that time, they were honored, and they were not the only ones. They happened to be at the dinner dance, dancing, right? Who are well beyond 20 years with their heart transplant. So for those of you amazing people, how many here are within 1 year of your heart transplant? Way to go. How many 1 years to 2 years? All right. 2 to 5 years. Whoa, look at that crowd. All right, 5 to 10 years. Look around, see these hands up. Keep them up there for a minute.
Yeah.
10 to 15 years. Way to go, Chaz. Maureen. These are people with heart and lung transplants, by the way, even more challenging. Very nice. 15 to 20 years. 20th year this year. Anybody beyond 20 years? Last time we did this in October, we had somebody there who was more than 20 years. So just know.
Does 20 years working in transplant work?
Well, it's probably been equally challenging for you too. And so I caution you, think future. You know, I know sometimes just getting out of bed is a challenge, right? And those first couple of steps, my motto is just keep moving. Stop moving, they're going to bury you. And so with that advice, this goes back 20 years ago, October 19th this year. That was me coming home after 7 days post-transplant, and I've been moving ever since. And I'm not saying it isn't an uphill battle as you add 20 years to a youth of, I guess it was about 50 at that time. And this was a couple years later at the U.S. Transplant Games. That was a picture from the front page of USA Today newspaper. I am not really a swimmer, but this is to promote the success of transplantation. So I got in the water, I did not drown. And so in 2005, I actually retired after going back to work a dozen years after the transplant. And in 2005, I gave my gifted heart back to Pam, a donor mom in marriage. And that's Pam over here in the pink, next to Linda. And so one of the things that we do, we share our lives both as a donor and a recipient to any audiences from coast to coast to raise awareness and to get people to say yes to organ donation so that people like ourselves here can be alive to share the lives that you're sharing, be that children, grandchildren, family, whatever, okay? And so if there's some secrets to this, and I don't think they're really secrets, but the first one I would say is certainly compliance. If you have issues with getting your medications or any of those things, this team is here. You need to call them. You know, don't go making decisions on your own. Don't say, well, you know, maybe if I cut this pill in half, I can extend. Do not do that, right? Be compliant. And I know some friends say, well, I couldn't be bothered going in for my annual. Guys, I'm going to tell you something. I think we have an advantage over those who have not been transplanted. Because we have a team that watches closely, puts us through tests sometimes we didn't even know we're going through, and calls later and says, this is what we found, do something about it. Where you never had a symptom, you never knew it was there, but because of that regular oversight, we get these things caught early enough that they go in and fix. Kidney patients, they go back to the nephrologist. Heart patients, lung patients, we've got a dedicated team, and they are doing everything they can to keep us alive and active as long as we can. We're going to die someday. Face it, get over it, don't worry about it. Just live the best you can now and be thankful for what you got. So get active, involved, paying back. We have a second chance chapter here at HUP. Basically, we do 3 events a year. It's 2 like this and then the holiday party. So if you have missed out on any of those, by all means, you'll get notification from them. You have the Gift of Life Donor Program, which is the organ procurement organization for the region, and they are the ones that do the coordination between the donor families and getting those gifts to where you survived as you have today. They enlist volunteers, both as speakers to share your amazing stories. They will train you about the facts of organ donation so you can add that to your stories and show your community why they should say yes to being an organ donor. Secondly, they also have a Gift of Life family house, much like HUP has a family house, and both those houses depend on volunteers like yourselves to come out and do things. It could be maintaining the front desk, answering phones. It could be coming in, cooking a meal. Pam and I work with the Gift of Life Family House, and so that's 30 rooms for patients who are more than 25 miles away, can come in and stay overnight for $40 a night here in Philadelphia with an amazing facility, just like the HUP facility, so amazing facility. So if you are a distant patient and you haven't investigated those options, they're there for you. And there are also opportunities for you to give back in thanks to often an anonymous donor that you don't know, by paying back to patients who are waiting. And it's an amazing thing to be able to be there serving them and for them to find out you're a recipient. You give them hope. You give them inspiration by the fact that you're there doing what you do. TRIO is a transplant recipient international organization. I have some brochures up here if you didn't pick them up out there. We have a local chapter in Philadelphia, and one of the things that we did, just to give you an example, a year or so ago, we actually created a book for children. This is for children of your family, okay? So that they can understand what transplantation is about. So it's not for a child getting a transplant. And one of our lung recipients shared her story. We dummied down the phrases, and we had the children of our transplant families actually create the artwork to illustrate each of those phrases. And so we published this book, and yeah, it's got a USBN and all that kind of stuff on the back. And we actually have never sold one. We give them away. We're in our third printing now. And we try to put them in the hands of social workers so that when they have families, or they have grandchildren or children that need to know what's going on, they can give them this. And so if you have a need for something like that, I didn't bring a bunch of copies, but I'll be glad to send them to you. Or you can check with Debbie sometime when you come next time. I'm sure she has more copies. So that's one of the things that TRIO does, among others. And then we have United Network of Organ Sharing, which is the government subcontractor that takes care of everything in terms of allocation rules, the database where you are listed, right? Your profile, all your medical records were put into that system to supply the information that allocation rules use to say who's next on the list. And so when a donor says yes, a list is generated for each of those organs, and they start at the top asking, are you ready to take this one? And quite often it gets passed on down. So they have 22 committees that really are the mainframe of what UNOS does. And patients are a key element in those committees. So when you think about what can I do with the gift I've been given, one of the things, if you're able to travel, the expenses are fully covered, like to serve on one of these committees. It could be patient affairs. I was fortunate enough 10 years ago to serve on the Thoracic Transplantation Committee. Thoracic is lungs and hearts. Can you imagine sitting on the committee making the decisions about how a heart is going to be allocated as a heart transplant patient? I was kind of in awe. There was 20 medical professionals, surgeons, cardiologists in that committee, and I was kind of in awe until I said, wait a minute. They've done them, but they never had one. And so I did start to speak up, and I got to tell you something. They were very respectful, and they listened because they didn't know what it was like to be a patient. You have a lot of gifts to offer, is my point. So find your passion for living. Why did you do this? I mean, it wasn't fun. So what is that passion? What's your reason for living? It's probably your family, your children. And then by all means, do just what you did today. Network for success. Come on out to things like this that are offered. We have the luncheon over there. Don't sit down next to the person you knew when they were in the hospital. Go meet some new people. Find out what's going on. And let's face it, we got a community here where it's very easy to say, so, when did you get your transplant? Oh, you're the spouse of the one that got the transplant. I mean, many of us look so healthy, it's hard to tell. Isn't that great? Life is filled with opportunities. I want to share one opportunity. I just mentioned UNOS. UNOS, for the first time, is going to have a patient as the president of the organization. And there are 2 of us who have been nominated. The elections are taking place right now. So HUP, for example, the Transplant Center gets 1 vote. And there's 400 to 500 members of the organization that are voting. And on March 5th, it'll be announced as to who got elected as vice president, which is the president-elect. And so I'm one of those nominees, and either there's a living kidney donor who's a lawyer who will become the president of UNOS, or one of our heart patients right here at HUP will become the president of units. That's an awesome thought, and I just want to share with you. That's how close that organization comes to here. It hasn't happened yet. But the opportunity is made possible by often an anonymous donor whose heart is still beating here today. Roberto Cuevas, I happen to be one of those 1 or 2% that actually meet their donor families, so don't expect that to happen, but it does in some of the strangest ways. And so I can share with you, Roberto, and Roberto was dead. Was his heart dead? I don't know if you could say an organ is dead or alive, but if it was dead, I wouldn't be here sharing it with you today, would I? And so just think about that, about your own transplant, your heart. Somebody is living on through you, and that's an awesome thought. And so there are many opportunities. We have a celebration of life dinner dance with that second chance coming up Sunday, May 4th. It's in the afternoon during the day, so those who don't like to drive at night, not a problem. The information is on the website. Anybody needs any other information, the contact information is in that second chance brochure. Come on out, it's a fun thing to do. And I saw an article recently about, out in, I believe it was Ohio, they got together 139 heart recipients at some car dealer to break the Guinness, to set Guinness Book of Records for the greatest number of heart recipients together. I happened to mention that to Dick Harvard, who's the chairman of Second Chance. And he's now trying to bring more than 139 people together with that heart transplant to this dinner dance. And we just registered over in England with the Guinness Book of Records to apply to do that. So all of you heart recipients out there, think about coming out to this and see if you can help us break the Guinness Book of Records, okay? Trio Web, another website out there. We have a candidates workshop coming up May 10th, so for those of you who know people who are waiting, we offer this over at the Gift of Life Donor Program. It's a Saturday event where we have patients talk about and presenters talk about all the aspects you need to know about transplant. Probably too late for you, but for the candidates, spread the word, okay? And finally, the Gift of Life Donor Program, there's the website, donors1.org. If you're interested in participating in the transplant games down in Houston, Texas this summer, the information is on their website. Amazing thing to do. Every other year in the United States, there's this transplant games for people to participate in athletic events to show the world that transplantation works, so that they can register to be organ donors because they can save a life. So, and then finally, once a month, we typically have a speaker over there. In March, we have the mother of 2 very challenged children who's coming to share the story behind her book that she did. And in April, we have a transplant coordinator from Einstein Medical Center who's also a liver recipient. I'm talking about what it's like to be on both sides of that. And then quarterly, we have a transplant movie night on a Saturday night here in Philadelphia over at the Gift of Life Donor Program. All free, protected parking. And we show a movie, and then we have discussion afterwards about something that was related to the transplant story in that movie. And so, I offer you the daily challenge, okay? We don't defeat death with a transplant, rather we gain an extension of life. And so, the real question becomes, what are we going to do with the days, months, and hopefully years of that extended life? Same question, even those of you who haven't been transplanted have to face every day in your lives. My inspiration is something I heard just recently from somebody who said, you know, my motto is, I want to live until I die. Doesn't that really say it all? And a special thank you, first of all, to Dr. Blumberg, which you did, but also with the 3 of you, come on up, as has been our habit, and I hope I'm not duplicating it. These social workers really have become quite a marketing team. And those of you who didn't get the email and respond that way probably got a phone call following up on the spreadsheet that I give them every day to see who has not responded yet. So come on over, Deb, Sally. And one of these books is one you already have, just swap. I thank you very much. We all thank you. We all thank you. Hey, thank you very much. And lunch is ready?
Lunch is ready. We're all ready.
All right. Don't forget, is Zora here? No, okay, so that didn't happen. Did everybody get a parking voucher that needs it?
If the people that came in late, I got some, I'll be by the door.
And we got brochures up here for those that didn't get brochures. And with that, go on out, have lunch, and Debbie has something.
Just want to say thank you to the Solid Hearted Gold Fund for making these special speaker programs happen each year, twice a year. And it's incredible, and we are very grateful to have your support. Thank you.
Thank you.